My name is Shelby Allen. I've been a nurse for 8 years now. My specialty is cardiac.
So I'm Tessa Brock. I got into nursing straight out of high school.
My name's Megan. I got into healthcare. My mom is a nurse and my parents have both worked in healthcare since I was small.
So we have a few clips for you on medical shows. So we're gonna get started with the first one here.
Oh, I love this show.
John, what's this?
It's a laryngoscope. No, second shelf from the top.
Hey, can you teach me how these work?
Some of the time.
The paddles are definitely out of date. We don't use paddles anymore. We have patches that go directly on the patient, and so it has a monitor on it, so we can also monitor their rhythm while we're doing it, because again, there are certain rhythms that we do shock and don't shock.
My mom used to watch this all the time. Okay, pause. First of all, crash carts are checked at the beginning of every shift, and at the end of every code, they're restocked. A crash cart should never be this cluttered or messy. Everything has a place. The place is typically labeled. There's a sheet to say laryngoscope is there, everything's there. You check it. Before I even would take report, I'm like, okay, get your stuff done, but I'm gonna check my crash cart off, because the moment you don't, something won't be there and there will be a code. Yeah. His symptoms aren't really realistic for what's...
We gotta stabilize him first.
Okay, also, we would never put oxygen on only. It would be the Ambu bag if we're getting ready to do
shock, CPR, anything. There would be an Ambu bag and it could have oxygen connected to it. I mean, there's been times that, you shock patients to get them back into a normal rhythm. We call that cardioversion. Typically, they would have given med and put them under anesthesia because it's a jolt. It's like getting hit by lightning. So a lot of patients choose to go under anesthesia for that.
Carter, we need this crash cart and floor, body packer, pop the condom. Got it? Let's go. Give me some room, huh?
Here you go.
Stay here and try not to get in the way. Can't you cut him open and pull out the coke? We gotta stabilize him first.
These have multifocal PVCs.
They talk about multifocal PVCs. So PVCs are a type of arrhythmia that we can have that if you continue to have PVCs over and over and over again, it turned into VTAC. Now in his instance, he went into VFIB, so I feel like it most likely probably would have gone in VTAC. Again, there's no mold for one specific patient.
Yeah, okay, lidocaine, 150 IV push. He's in fib, paddles.
Okay, that.
Also, she had paddles out before he called for them. They would have just moved her out of the way, I feel like. They would have told her, stand by that scale, touch nothing, observe.
Be a fly on the wall.
How would this have affected the other nurse being shocked?
It's just a jolt. They would have probably passed out and come back to.
Except for the head injury.
Yeah, that they hit their head. Really, we would be more concerned about the head injury than the shock. So like 200 joules, you probably pass out. Your body's gonna reset. It'll be fine. But he probably hit his head on the way down, so we'd be more worried about having a brain bleed or some trauma to the head. It's like a high-powered taser.
But do we use those ones anymore?
No.
Are those the kind?
And it's not even...
Because I've never seen that.
She's shocked here and here, so it probably didn't go through the heart this way. Usually you would shock here. You want to be somewhere either to give a diagonal or front and back, which is why we do the pads on kids front and back, so that it goes through the heart to shock it. So being here and here, it was probably more like a taser.
Okay, lidocaine, 150 IV push. He's in fib, paddles. What was that set on?
200.
Well, he should be okay.
So as far as him getting shocked by the paddles, obviously that didn't happen anymore because we used the pads, but I just think it's kind of funny. I don't know if he got shocked in that instance, but it would have been best to hook him up to a monitor to make sure that we didn't put him into any arrhythmias, because when you shock somebody, it's kind of like being electrocuted, you always have to make sure, you're messing with the electricity of your heart, that he himself is not into any lethal rhythms.
What was that set on?
200.
Well, he should be okay. Thank you. Why don't you check on him, okay? Yeah. All right, clear.
It's about prioritizing your patient.
No, that's not good. Let's go again. 300? No.
Okay, pause. He should not be talking. Am I right?
I'm confused about his symptoms not matching up with what he's saying.
He's in cinema fib. Instead of AFib, he's in movie fib.
He wasn't even in AFib until right before they shocked him. Cardioversion is like getting kicked in the chest by a horse when they're trying to shock your heart back into a normal rhythm, which is why. It wouldn't be like no. It'd be we would have probably gave lidocaine on one side, flushed it, little Versed, and then done the cardioversion. Maybe he's in some AFib instead of having just minuscule PVCs, because people live every day with PVCs, which is a premature ventricular contraction of your heart.
It just feels like you're getting like hit in the chest, but it's not anything.
It's not anything that's going to cause thrashing in the bed. I would think more of atrial fibrillation crisis, and maybe he's never had that before, so something's causing that. In which case they may cardiovert him in the bed, but they probably would have gave him a little Versed to calm his body down during that.
Thank you. Why don't you check on him, okay? Yeah. All right, clear.
Clear.
No, that's not good. Let's go again. 300.
No,
Clear.
No.
He shocked him, and you could tell he was visibly like, no, don't do it again. So you always have to like look at your patient and do a pulse, and not with the one thing that as soon as he went to VFIB, you always have to check and see if the patient has a pulse. You know, you can't call a code necessarily until they don't have a pulse anymore. And so I feel like if he was like yelling, oh no, please don't do it again, he probably had a pulse. VFIB versus VTAC. So VFIB is ventricular fibrillation. What that means is the heart is just quivering. So it's still moving. So asystole, it is not beating at all. So we don't shock asystole because there's no electrical activity going on. So VFIB means that your ventricles, so you have your atriums on top, your ventricles are just quivering. So it is not pumping effectively to get the blood out to your body, just quivering. And we can shock that because you still have electrical activity going on. It's just not effective electrical activity. So we shock that and hope that your heart will start beating normally again. VTAC just means that your ventricles are still pumping, but your atria are not doing anything to help. So essentially your heart is not refilling with blood in order for it to pump out to the rest of the body. So essentially it just gets empty and it's just moving, but there's no blood pumping through your body to get to your vital organs, which is why you often don't have a pulse when you have that long of a VTAC, because there's none of that blood coursing through the body. And again, we can shock VTAC because there's electrical activity going on. It's just not effective electrical activity.
What would you say to someone who's interested in healthcare?
I would say make sure you have a passion for people. You have to have a certain level of caring for the people to want to treat them, to want to learn, and to want to do better.
What would you say to someone who's interested in healthcare?
So I was actually thinking about this on my way to work today, that I am the one out of my peers that loves my job. By getting this degree, by having my nursing degree, I get to wake up every day and be a part of somebody else's life and impact them in such a cool way.
And I think that there's so many different aspects of healthcare. So even if a 12-hour shift on the floor taking care of 7 or 8 patients isn't your jam, there's always something for somebody.
Look at us now, we're teaching.
There are nursing positions where you can work from home. You can work in a Fortune 500 company as an occupational health nurse, or you can get down and dirty in the ER.
But like working in healthcare, you really get to make a difference.
Thanks for watching. A big thank you to Shelby, Tessa, and Megan for joining us today and sharing their expertise. Nurses make a big difference in our lives, and nursing is in high demand right now. Being a nurse, you can make about $60,000 starting out, and it can definitely go up from there. And if you want to learn more about nursing, check out your local technical college. If you enjoyed this video, make sure to like and comment. YouTube Analytics says only 1% of you are subscribed right now, so make sure to hit that button, and we'll see you next time.